Hi, my name is Andrew Penn. I'm a psychiatric nurse practitioner and a co-founder of OPENurses, and I want to welcome you to our very special event today, where I have the distinct pleasure and honor of interviewing Annie Mithoefer, RN, BSN, who really needs very little introduction. As many of you know, she has been a key part of research into MDMA assisted therapy for PTSD. So as we get settled in here, if you could just take a minute and mention in the chat where you're coming to us from, if you're watching this live, would be fantastic. And then after we do the introduction here, I'm going to just ask if you could go ahead and hold off on your questions until we get a little further into the interview so that we can all really be fully present for Annie here. So Annie Mithoefer, BSN, is a registered nurse living in Asheville, North Carolina. She was co-investigator on 2 of the MAPS-sponsored phase 2 clinical trials for individuals with PTSD and a pilot study treating couples combining MDMA-assisted therapy with cognitive behavioral conjoint therapy for PTSD. She's currently a co-investigator in MT1, which is a protocol allowing MAPS-trained therapists to receive their own MDMA-assisted session, and she conducts MAPS therapist trainings with her husband, Michael, and is a supervisor for phase 3 therapists in the MAPS studies. She's a Groff-certified holotropic breathwork practitioner and is also trained in Hakomi therapy. So please join me in welcoming Annie Mithoefer to the OPENurses interview series. Annie, thanks for joining us. I know it's getting late out there.
Thank you, Andrew.
Yeah,
that's so nice to be here and with all the nurses that are here tonight.
Yeah, we have people tuning in from around the world, and we'll be watching this also on our YouTube channel, recorded later. So, but as I said before, this is just you and me having a cup of coffee.
That's good.
Yeah,
I'll try to remember that.
Yeah. So, as I said, people can put questions into the comment section, but I would encourage our viewers to just settle in and listen to what you have to say, and then we'll take a few questions from the audience later on in the hour that we have together. So as we get started, I would, one of the things I find fascinating about nurses is there's so many different routes to the same destination. And I'm always interested in how nurses got to where they are. And so could you tell us a little bit about the trajectory of your nursing career and how did it land you here working with psychedelics?
Well, good question. So my first job as a nurse was in a step-down unit at the University of Virginia. It was a step-down unit for the coronary care unit. And we did have some, very sick people on respirators that would come from other floors. But most of our patients were people that had MIs or pacemakers and had come out to the floor and needed teaching and help with how they were going to change their lifestyle. And, so my beginning was a lot of deep processing with people about the changes they were seeing. And I really loved that. And so moving forward, Michael worked in the ER and was able to take large blocks of time off because he would work large blocks of time. And so as our kids were growing up, we did homeschooling and we did a lot of sailing. And I didn't come back to nursing till later when Michael became a psychiatrist.
Okay.
And so by that time, Michael was a Groff certified. He started doing the Groff certification at the same time as his psychiatric residency. And then I joined and did the Groff training. And so we really started working together in a private practice and seeing a lot of people with trauma and leading breathwork groups monthly with some of the patients and people that were referred to us, and also people from the community. So, Michael and I are both really process oriented. We like deep states. And I'd had my own experiences with MDMA when it was not illegal, well, before it was scheduled. I'd also had it with Michael as a couple and found it incredibly useful. So we had, that experience. And over the years, we were trying to find new ways to help people because breath work didn't always help and medicines didn't help. So we did neurofeedback, we did EMDR, and where the way we would work together would be sometimes Michael would see patients. We worked a lot with dissociation and patients who had DID. And so if I was at the office, we would be able to work together with some of the people and do similar things like we would do in breath work, like mat work, where we would do body work with people and work with their different dissociative parts. So really the practice was a large majority of the people were PTSD. And so we knew about psychedelics and we thought maybe we would have to go offshore to do something like that, but met Rick, and Michael asked Rick, and Rick said, we would love to help you do this. And so that's how we kind of got started in the research. Yeah.
Oh, that's fascinating. I think it's great that you started your career working with people with heart problems.
Yeah.
And so often people talk about MDMA as being really a heart medicine.
Yeah.
In the metaphorical sense, of course, but the spiritual sense.
Yeah.
So for people that are unfamiliar with Groffian work or breath work, could you say a little bit more about that just as a primer?
Yeah. So the Groff work was started by Stan Groff, who was one of the lead LSD researchers in the early days, like the 50s, and then came to the United States and worked until LSD was shut down in the 70s. But what he ended up doing was starting a training where he put together breath and music and groups and a combination of like having a sitter and a breather who does the breath work, which is basically hyperventilation, which will bring you to a non-ordinary state. So it's very similar to some of the states you would have in psychedelics, but it's without a medication. It's with breath and music, lots of percussion music to get you into that state. So the training itself is, you can't do it in less than 2 years because Stan really felt like you're doing your own work. And he felt like it was important to have that time for integration. And so there are modules that you go to. And so it is, along with that, you're also seeing other people do their own process in these groups. So the groups would be, when I was in the training, they would be groups from all over the world, people from all over the world. And so you'd get to see the kinds of things that, people that had parents in the Holocaust or grandparents. You'd get to see other processes that were really deep and sit there and witness. And so for me, it was just a life-changing event. And I learned so much, learn to be in those deep states with people, to be a sitter and not doing anything, but just providing support.
To witness and support. And, and as you were saying that, it got me thinking about another sort of common non-ordinary state that nurses may be very familiar with, which is childbirth.
Right.
Where breath is really central. I think about, the old Lamaze techniques and breathing and how, nurses really witness and guide a very natural process. We don't, we can't make somebody birth. We can only assist in a natural process. And in that way, it's not dissimilar from psychedelic therapy in that it allows people to go through their own healing, their own process while being witnessed.
Yeah. And in the breath work, people also birth themselves.
Yeah.
Because it is a process of self-discovery, just like psychedelics. And yeah.
Mhm.
Mm-hmm.
Yeah, that makes sense. Well, that's a good segue to another question, which is, do you think that nurses bring a different or unique perspective to psychedelic therapy work? And if they do, what do you think that is? What's different about nurses?
Well, I think nurses are really good listeners. They're, they're medically trained so that they know what to look for with their patients. They're the ones that spend most of the time with patients. I mean,
Mhm,
when they're with patients and that profession, the doctor is not with their patients that much. They are keen listeners and look for signs and symptoms of things that have gone wrong. They're
mhm,
used to deep processes with people, grieving processes and
mhm.
birthing, like you said, and death and helping family members. So, yeah, I
Yeah,
think they're great for it.
and yeah,
Good
we
observers.
we agree.
Yeah.
What do you imagine the future of nurses being in psychedelic therapy? What does that look like?
Well, I hope they'll be part of it.
Mm,
I think right now, the way we're asking the FDA to, if we get approval, we're asking the FDA to have only one person that has a master's or higher level degree.
mhm,
But I think, and so that means that a nurse could be a co-therapist. But if a nurse actually had a higher degree, like a nurse practitioner, like
mm,
you or master's levels,
mhm,
they could maybe become the lead therapist and be the give the medicine. So
mhm,
you wouldn't have to have a physician to
mhm,
do that. So nurses have always done lots of clinical research,
mhm.
and are hopefully they'll do more of that. And there's so many things that we could study.
Yeah.
Yeah.
Yeah, there's some interesting things published from the pre-prohibition era of nurses, that nurses would often be the person with the patient on their 8-10 hour LSD therapy session. The doctor would sort of pop in at the beginning and end, but
Right.
really it was the nurses who were there.
Yeah.
Kind of like the ICU. You're there for the whole 12 hours, and
Right.
you deal with whatever comes your way for those whole 12 hours,
Hmm.
whatever non-ordinary states that patient is having.
Right. Yeah. Hmm.
So, speaking of working collaboratively, nurses are found in all areas of healthcare, and you've mentioned your husband Michael, who I think we can say he's a fairly well-known guy in psychedelics world. Um, he also happens to be a physician. We
Yeah.
won't,
Hmm.
so I'm wondering, what is working with him taught you about how nursing and medicine can complement each other in the field of psychedelic therapy?
Yeah. Well, for me, that's a hard one to separate because we've been married for 50 years.
Oh.
And, so the relationship we've had working together has working with a doctor kind of a nurse and a doctor relationship, which has
Mhm.
been part of it. And also us just being a couple. And I think, for me, trusting my education,
Mhm.
my intuition,
Mhm.
has been things that I've had to work with. And of course, there are things, I'm more grounded in a way. I'm the one that's looking for what could go wrong.
Mhm.
Michael's always thinking that everything is going to go right, and partly that's part of maybe a doctor knowing that someone else is going to take care of what's happening and make sure everything goes right. Like you said, the nurses are there for the 12-hour shift, 8-hour shift, and so I think part of that has been inherent in the way we've worked together,
Yeah.
learning. And then I think any therapy team would be working on the things like the timing that you bring to the session, how your timing is different from the other person, and how to work with each other in the way that you work individually.
Yeah. One thing I didn't mention in the introduction is that I had the privilege, along with my 3 other co-founders of OPENurses, of training with you and Michael in the CIS cohort a few years ago. And so what that meant was that we all spent a week together on a retreat in Northern California, and most of the day watching these videos of MDMA therapy sessions that Michael and Annie were running. And, I think we all left that week kind of in awe, a little intimidated, feeling like, oh my goodness, can I ever be that good in the room? And I think we all wanted you to be our mom and dad.
There's a lot of transference.
Yes.
We've been together for so long, but yeah.
Well, and it came out in the sessions too. I mean, I remember one of the participants, kind of held, was almost sort of holding your face and said, your kids are so lucky, and I was like, wow, that's not like your everyday therapy, right? To have that level of really intimate, really sensitive, really delicate transference happening.
Yeah.
And I think we were all really so, admiring of how the two of you work together, and how that, that held that space in such a really delicate way.
Thanks, Andrew. Yeah. I think a lot of that really is part of the breathwork training, and being with people, and be comfortable with people, being in these intimate regress states. Yeah. And also in nursing, I mean, I can imagine, I worked with some hospice patients and bereavement, and, that people could be very intimate with what they're sharing.
Yeah. I mean, that is one of the beautiful things about nursing, is that people really trust us.
Right. Exactly. Yeah. And they want to listen to us.
Yeah.
I mean, for the most part.
Yeah. we have probably more power than we realize sometimes, more influence than we realize. I'm wondering, so you mentioned the Groff breath work, and I'm wondering, we talked also a little bit about your training in Hakomi, but I'm wondering, what sort of training do you feel like is complementary to psychedelic therapy work, in addition to just one's nursing training? Could you speak a little bit about that?
Yeah. Well, the Hakomi training for me was, I started the Hakomi training halfway through our first study. And so it is another type of training, just like IFS, where you're doing your own work while you're learning some of the Hakomi methods. And so it was so useful for me to have it. The meetings would be 4 times a year, and to have a chance to go to the group and process as I was doing that study, and, releasing somatic things, that maybe things I was holding in my body. And another way just to be with other people that were growing and learning about themselves. So that was a great thing for me. I think the Enneagram is another thing that is really useful to learn about yourself, and to learn about how you're, the things that you carry, and some of the things that you could grow, to be a better person. And also how you might work with another therapist, so you learn to complement each other. Michael trained in IFS, and, I've done a bit of listening to some of the IFS lectures. That's internal family systems. And I think that really does complement psychedelic therapy. I think people do have a tendency to bring up other parts of themselves in their sessions. And also, you might see somebody's self-energy show up in a bigger way, which, you don't have to use these techniques, but I think they give guidance and some ways to work in integration too, which would be useful.
Could you say a little more about what that IFS and self-energy? You said self-energy.
So IFS is is a way of working with your parts, your inner parts.
Okay.
And so we all have like the higher self, the self energy that Dick Schwartz, who developed IFS, uses words like caring and compassionate and curious to know that you're in self energy, where you're really holding those places of compassion and curiosity. And then the parts that that come up are things like a part that might be angry at your mother, or a part that feels like they didn't get enough when they were a kid, or things like that. And so those parts tend to come up in a more magnified way, I'd say, especially in MDMA, because I haven't done any research with psilocybin, but especially in MDMA, when you're looking at trauma and somebody's biographical life, those ways of looking, part of me wants to stay with my husband and part of me is not being fulfilled in this relationship. And so the way IFS is organized is just working with those parts and hearing from those parts and learning what burdens they're carrying.
Okay.
And so it really complements the work.
Yeah, I can see why it would. And the way you describe it, it almost sounds like the parts of ourself that are maybe more wounded or younger can be cared for by the parts of ourselves that are a little more developed, a little more mature, a little wiser in that setting. Is that a fair?
Yeah,
summary?
definitely.
Okay.
Yeah. A lot of the younger parts that are vulnerable may not want to show that vulnerability. And then we have other parts of ourselves that have helped us get through our lives if it has been a challenging time, or growing up has been a challenging. And those parts tend to be, they're called protector parts, but they tend to operate for us to keep us safe. So it's looking at all those dynamics between different ways that you've gotten through your life, and you could talk about it in emotions. You could carry a lot of grief there around about your childhood, so you don't have to talk in the parts language, but I think it's another way, just like Hakomi is a really good way of helping people with mindfulness to be inside and have an inner experience, which some people are not used to that. And other techniques about looking at what people are carrying in their body. Hakomi is a somatically based psychotherapy. So both of those for me have been really useful. I think one thing about the MDMA therapy is that the integration part is really some of the most important part. You have that MDMA session and it's a catalyst. And so having ways to work with people in integration is really important. Yeah.
I loved what you said about curiosity. I think it was Bessel van der Kolk that said something about that. It's impossible to be curious and afraid at the same time. Because those two mental states really are just opposite of each other. And that MDMA invites that kind of capacity to lower your guard enough to be curious about how you were wounded and how you might feel. And that we can witness that.
And if you're not curious, you can notice why not, and what is there and what's taken over that.
That
and
makes
what's
sense.
keeping you from being compassionate or curious.
So I've heard Groff breath work as a form of sort of complementary training to this, Hakomi being another. Do you feel like there will need to be specialized training for nurses, for any clinician for that matter, who want to do this kind of work? And if so, what do you imagine that training looking like?
Well, I think it could be, there could be advanced trainings. Like right now, MAPS is working on as you know, redesigning the training program. So there could be a way that there could be an advanced training that incorporated some of the things that we haven't gotten to really go into in the basic training. And one of the other things is music. You know, we haven't spent a whole lot of time in our training on really helping people make music for their sessions. So maybe some kind of advanced training that incorporates a lot of those things, like Marcella and Bruce in Boulder use somatic experiencing, which also would be Peter Levine. That would be also some of his work. So yeah, I mean, it's a lot to think about. Well, going and doing a whole training and spending the money to do all these different trainings. But, you know, some of them like Kokomi and IFS have introductory weekends that you could go to, and you could go to, you know, one module, breathwork module, and see what you think. And you could probably get a lot out of it.
Yeah. Yeah. I imagine you get emails like this where people reach out to you and say, you know, I'm a nurse, or I want to become a nurse, and I want to do psychedelic work. What should I do in order to prepare for that? Yeah. I'm wondering how you answer that question.
Well, I say, you know, working on yourself, I think, is one of the most important things, whatever way that works for someone, like whether it's meditation or one of these trainings that I'm talking about where you're doing deep work, or I mean, unfortunately, we can't use psychedelics legally yet. And hopefully that's going to change, but there are places that people go and do that. So yeah, I mean, I encourage that.
Yeah. But I'm really hearing that over and over again, that really people have to work on their own internal lives as well in order to heal other people.
Definitely. And to be with people in a way so that you're not, so that you can be comfortable in an extreme state and you're not falling apart, and you know how to be grounded there in that.
Yeah, and I know some of our members have worked in things like the Zendo project, where they can have the opportunities to do harm reduction work, where people have taken a psychedelic, and or maybe they haven't, but regardless, they're having a pretty difficult time, and they need somebody to be with them and to hold that space. Yeah. Do you see that being a useful way of getting kind of hands-on experience?
Yeah. So I wasn't at the Zendo. They didn't have the Zendo yet. I was at Burning Man before that was the Zendo. And I mean, I found that really useful, being in the tent and being with people. It's a little bit different because some of the states would be a little bit more extreme than because of the number of psychedelics people had taken, plus alcohol. But learning how to just be with. And that is a place that it's available to do that work.
Yeah, when I worked in Zendo, I thought, boy, I wish every psych ER was like this. You know, this sort of gentle, kind space where you know, people come. You know, you come in and people say, you know, stay as long as you like, you know, as long as you need to.
Yeah,
you know, have a warm blanket and some tea, and you know, here's a nice person to talk to, and you know, there's no rush. Yeah. So, you know, pivoting a little bit, you know, nursing, we're an interesting profession because we can be both kind of radical and really conservative at the same time. And so I'm wondering, you know, you've been doing this for a long time, and so, you know, when you first started maybe talking about working with psychedelics, how did people, especially other nurses, respond to that?
Yeah, you know, I don't feel like I got a lot of bad feedback from nurses, but in the beginning, when we had the first approval from the FDA, there was a Wall Street Journal article that came out that actually Michael had spoken to the reporter, and he got the article at like 11 o'clock at night, and we were trying to do the research at the Medical University of South Carolina, but we hadn't gotten approval from them yet. We had gotten the FDA approval first. And so when Michael saw the article and saw that she was saying that we were doing it at the Medical University of South Carolina, which we actually weren't yet, he said, you have to take that out of the article. That can't be in there. And so she said she would take it out. And unfortunately, all the early editions had that in there. So South Carolina, Charleston had that in the early edition. And Rick had also referred to us as psychedelic psychotherapists. Which, I didn't think of myself as that. I thought we're going to do clinical research. And so there was a gigantic backlash. And, people, there was so much press and so many people calling the provost office, the president's office, saying what is going on, that it was a pretty rough time for a while for us. There would be articles that would be written that would make it sound like Michael was giving MDMA to his regular patients in his back office. And so for a while, it was pretty rocky. The press was always like, if you saw something on TV, they'd always have the rave scene and the baskets of MDMA. And but over years that has changed, and now they're talking about trying to do some kind of program at the Medical University of South Carolina and want help training residents in this field. So it has been a big change. But at first, I don't feel like I got it from nurses, but I feel like there definitely was that feeling that we were on the edge, which we were always kind of on the edge anyway, because breath work was not really something that, thinking about psychiatrists and nurses down on the floor with their patients doing body work is not the way people, think about how a psychiatrist should be. And a nurse maybe, but so we were always doing things that were a little bit ahead of other people and used to that. But it was also, it was scary. The feedback and
So it felt risky when you were doing this initially.
Yeah, it felt very risky. I felt like I couldn't answer the phone in the office. It was tough. Yeah.
Yeah.
And people didn't understand. I don't think people understood. Once we got the first paper published and the studies published and they were recognized, then it all changed. But even for the psychologists that worked on our study, on our first study, had a dual appointment in neurology and psychiatry. And he was the independent rater who was going to be doing the testing on all of our participants. And he lost his psychiatric appointment because he was working on our study. And all he did was do the independent ratings,
right.
So, just thinking about what how their profession is on the line, when they're associated with things that are out there.
Yeah. For
sure. That's happened with people with, EMDR too.
Right.
In the beginning, people said, "Oh, that's hogwash," and so yeah. But I'm glad it's changed. It's totally changed. I feel like,
and so that was what, the early 2000s?
Yeah.
You were starting that study.
Yeah.
I'm thinking, boy, how things change, because now in these top shelf universities, they're all competing with each other to start academic psychedelic research centers,
right?
And trying to recruit the top talent and that. And, here you were, having to almost kind of keep this under the radar for a while.
Yeah.
And in South Carolina, this wasn't.
Well, in South Carolina is not California, so yeah.
Needless to say, yes.
Yeah. So, but over the years, we've certainly had our friends that were part of the medical university that, so it wasn't completely like that, but it's a conservative place. So
yeah. And it's interesting because it seems like there's these sort of storylines that get placed onto whatever's happening in the psychedelic space, and I'm having seen the inside of your office, I can attest there is no DJ booth in there. There's no raves happening in there, but this idea that, some academic, and the leftover from the Tim Leary days,
Yeah.
that this is being given indiscriminately to students or to patients,
Yeah.
when really everyone I know in the psychedelic sphere is incredibly cautious.
Uh-huh. Yeah.
Which is where nurses are so important, right? Because that's part of what we do, is we protect patients' safety.
Mm-hmm.
Um, so,
Good
well,
point.
did you ever run into any problems with your licensing board or anything like that?
No.
No. Okay.
Mhm.
Okay. Well,
Yeah.
yeah, because this is one of the questions I get asked a lot, especially for people that, don't live in California or New
Yeah.
York or someplace, that say, I'm in a nursing program and I'm taking my psych class, and I talked about this to my professor, and they said, well, that's a drug of abuse,
Mm-hmm.
so
Yeah.
to be able to hold that space.
But I mean, really, for me, I've been a researcher,
Mm-hmm.
so I mean that there's nothing illegal about that, and it's an FDA approved study. But I have heard of, residents, psychiatric residents who went in to speak with somebody about wanting to do this for their field, and the higher up saying that would be, a deal changer for you. You would maybe not, for your profession, and your career.
Mm-hmm.
So yeah, I don't think that's happening as much. Like you said, I think everybody's clamoring to do it now, but in the past that has been, and you also think about Stan Groff, who
Mm-hmm.
had very promising research, and then it all got shut down. So yeah, we need to be careful too.
Well, this is one of the reasons why, as an organization, as Open Nurses, we wanted to talk to the people that have been pioneers in this field, because there may come a time in the not too distant future when these are FDA approved, and there's all sorts of different companies clamoring for market share and people wanting to get trained in this, and it'll be very easy to forget that there was a time when to be even peripherally involved in this made you a little bit of looking like an outlaw,
Mhm.
and subject to sanction, and that we
Mhm.
really owe a deep debt of gratitude to people like you who blazed
Mhm.
that trail, for the
Mhm.
rest of us, because it
Well,
makes it
thanks.
so that we can talk about this publicly and have an organization, and not worry about it coming back to haunt us.
Mhm.
um,
Yeah, it's so important.
yeah, no,
Yeah, to have the organization, and yeah, and hopefully things will only keep getting better,
yeah.
so that there will be more nurses in the field.
Do you see nurses having a role in advocating for change in policy and changes around laws, or thinking about like harm reduction in this country is
Mhm.
still kind of seen with a lot of suspicion. In
Yeah.
some countries like Holland, and that it's fairly common, but here, like drug testing, for example, at a festival is against the law.
Mhm.
Do you imagine nurses playing a role in advocating for changes there?
Sure. I mean, earlier you said how often we listen to, what a nurse says, and patients listen to us. And um, so I think that would be, I mean, it's an obvious place for nurses to be involved, and thinking of giving advice about the risk benefit
Hmm.
of certain things, and um, advocacy. Yeah. I mean, we're going to need lots of it probably.
Yeah. Yeah.
um, and advocacy for our patients, that people are suffering, and um, having patients that have been having PTSD for 10 years or
Mhm.
15 years or 19 years, and knowing that there's something out there that can help them,
Yeah. Yeah.
um, and yeah, working for that. Yeah, I think it'd be really important.
Yeah. Thinking about the last year with COVID and how nurses were really kind of the face of the COVID response, and how the what was being put out into the world by nurses really got people's attention.
Yeah, of what they were going through, and
Mhm.
yes.
And for the need for where change needed to happen, just
Mhm.
getting things as simple as PPE.
Right, right.
So I want to go a little broader. We've talked a lot about sort of individual healing and individual patients and treatment. And, sometimes people talk about psychedelics as having this capacity for sort of changing the world in a much
Yeah.
larger way. And, that it can easily kind of bleed into grandiosity. I think we've seen that at various points in the psychedelic history. But, I'm wondering, what are your thoughts about that? Do you think psychedelics will change the world?
Well, first off, I mean, what I've got to say is that with the FDA, I've got to be really careful because I'm a researcher
Yes.
on phase 3. So I've got to be careful about saying, that, acting as if there is something that we know is true about it. We only are doing research on
Right.
MDMA and we've seen some good results, but we also have to be careful about how we talk about it.
Mhm.
But, I think if I were to think about the research that I feel like should be done later, or, we found that MDMA, the studies helped with depression. So looking at MDMA and depression might be a good way to go. Communication. In the couple study, we had just, the communication was just incredible about their trauma. But, the couples that had never shared, one person in the couple had PTSD and the other one didn't. And
Okay.
they had never shared their trauma before. And
Wow.
so the communication that happened. And there's an eating disorder study that's about to start.
Okay.
Conflict resolution.
Yeah. Yeah.
When we did the training in Israel, there were Palestinians in the training and
Mhm.
people talking about how can we use these medicines to help with
Mhm.
some of the conflicts that we can't get through,
Yeah.
and just starting to talk.
So so that part about the couples, I'm fascinated by that. So, those of us who work in psychiatry, we often treat the patient, but we see the impact that the mental illness or the trauma, of our patient has on their whole family, has
Mhm.
on their partner, has on their children. And
Right.
so could you talk a little bit more about that study and how that worked? Did they both have MDMA or just one
Yeah.
of them?
Yeah, so they both had MDMA, but the way that probably we got approval for that study is that Candace Monson, who is also a co-investigator with Michael, and Ann Wagner and I were therapists in the study with them, is that Candace's model is that the couple is the patient, the relationship is the patient, and the relationship with PTSD is the patient.
Okay.
And so it's looking at, like you said, the ways that the PTSD is affecting the relationship, the family, everything. And so one person had to have PTSD, the other person, couldn't have anything.
Okay.
Yeah. And they both got MDMA on 2 occasions. And we combined Candace's method, like you had said in the introduction, cognitive behavioral conjoint therapy. And
Mhm.
Candace has a manualized treatment manual for that that's 15 weeks
Hmm.
long. But what we did was we condensed it so that we did like 5 of the sessions before the MDMA.
Okay.
And then we had an MDMA session, and then we did all the integration sessions were online on Zoom.
Okay.
And those were those other modules in her therapy. So the integration was all CBT, but it was the couple doing the
Hmm.
workshops
Okay.
rather than individually going home and doing their own work. They had to go home and look at their thoughts and their behaviors and their actions, and big pictures about how they could change those thoughts. But so we did 2 MDMA sessions.
Mhm.
We started out 3 weeks apart for those 2 sessions, I think, or maybe it was closer to 2 weeks.
Okay.
They did 2 MA sessions
Mhm.
and then all the integration. And It was remarkable.
Wow, that's fascinating.
It was really remarkable. It was really fun. I got to work with Anne, and I got to work with Candace.
Yeah.
Michael got to work with them. So it was fun for us to work with someone else
Yeah.
and do this work.
And it kind of harkens back to like the Leo Zeff period of
Mhm.
MDMA and using this in couples therapy,
Mhm.
which it really, to me, makes perfect sense. Remember why you love this person, right?
Yeah. Oh, yeah. It was beautiful. They would end up holding hands with each other, and
Mm,
yeah, it was really beautiful. And we had some pretty people who'd had PTSD for quite a long time
yeah,
and
yeah,
had some good results.
yeah. I would imagine the sort of compassion that could come out in that for each other and the couple
Mhm.
could
Yeah.
be really quite powerful.
And part of Candace's model is listening to each other. And
Hmm.
so, you would listen and repeat what the person said so that you really got it,
Mm,
which was beautiful to see people
yeah,
really doing that.
yeah. Wow, wow.
Mhm.
I can't wait to
Yeah.
see the results of that.
Yeah.
When those come out. So, a question for you, we throw this term self-care around a lot, and as you're talking about these couples, I'm thinking about self-compassion and compassion for your partner and for other people. Nurses have sort of a bad reputation for being hard drivers,
Uh-huh.
and I think it's Brene Brown that says, we wear exhaustion as a badge of honor. Like, how are
Yeah.
how are you doing, Andrew? I'm so tired. I've been working so hard, as if that's supposed to be something that you boast about.
Mhm.
But perversely we do. So I'm wondering, having been a psychedelic therapist as well, and knowing some of those days are those 8-hour days, it's amazing how exhausted you can be sitting
Mhm.
still for 8 hours.
Yeah.
you know,
Yeah.
Watching somebody lie on a couch and breathe with an
Mhm.
eye shade on, you would not think you would be so tired at the end of the day. So I'm wondering, what sort of self-care practices did you have before and after all these sessions that you've done with
Yeah.
subjects over the years?
So I think one thing about us doing the breathwork groups for a full day, you'd do a whole breathwork. You'd have a breathwork group, and it'd be all day. So what I noticed for myself was in the beginning, I would be so tired at night, and the next day that I barely could get out of bed. The next day, I'd be so tired. But over time, I learned to stretch and be able to be there for longer periods of time. And so I think with the long sessions, the MDMA sessions, I think by the time I started doing it, I feel like I had quite a bit of capacity to be there. But
Mhm.
it also, like in regular therapy, if someone isn't really processing stuff that is heartfelt, you may feel more tired. But if
Mm,
you're really engaged with a process, a deep process, it can be energizing to be there. But
yeah.
that doesn't mean that you're not going to get sleepy at 3 o'clock in the afternoon. And so, my self care for the sessions would be making sure that we're there before the session and getting organized and
Mhm.
grounded, not rushing around. Um, I always would do a little prayer for
Mhm.
myself, for the four directions and up and down,
Mhm.
and then tracking, your body and what you're holding and stretching,
Mm.
getting up and moving very frequently if you can,
Mhm.
and fluids and drinking, taking a break, and but then at the same time, self care would be making sure that you don't get in a position holding someone's hand or leaning over, doing something with your participant where you're really in an awkward position so that your back is going to completely go out. So watching your body mechanics, and because there are days where, sessions where you are holding someone's hand for a
Mhm.
really long time.
Mhm.
Um, and there are times where somebody doesn't even get up to go to the bathroom for 5 hours,
Mhm.
some sessions. So then
Mhm.
you have to really, say, excuse me, and get up and go. So
Mhm.
um, after the session, my self care is I love to cook, and I would pretty much cook a meal. I love nature, bird watching, So having some way of, processing what happened for you, getting supervision if you have a particular session or trauma that has triggered something in you,
Yeah.
or a participant that you're having more difficulty with, more countertransference, getting supervision about that,
Hmm.
doing your own work around that, keeping
Yeah.
track of your triggers. And
Mhm. When it goes back to that curiosity, right, of the
Mhm.
idea that, if somebody is really getting on your nerves, instead of beating yourself up for not being the perfect therapist, for maybe getting curious and saying, geez,
Yeah.
I wonder why they're
Yeah.
getting on my nerves, and maybe seeking some supervision out about that, or
Yeah.
talking about your co-therapist,
Yeah, right.
Um, yeah, because it's interesting when you have a strong reaction to somebody, but your co-therapist doesn't.
Oh, yeah.
Because then it's like, "Ooh, whoa, there's definitely some button getting pushed here. I wonder what this is. I wonder what's happening." Yeah,
Yes.
interesting. Now, have you had to do any of the therapy? You mentioned this actually for the couples therapy, that you do some of it over Zoom,
Mhm.
that you've had to do some of the integration work. Obviously, nobody's doing MDMA sessions
Right.
remotely, but
Yeah.
wondering how is it different there, and while we're talking, people feel free to put questions in the chat box, and I can ask them in the last few minutes that we have here, but
Well,
what certain things.
that worked really well. I was Michael and I were both really impressed with the integration and having a model for the integration,
Okay.
and having approach tasks, which, if someone doesn't like to go to the grocery store, that would
Mm,
be part of their homework to
okay.
go, or, working with anger, or working with sexual intimacy again. So these were different modules that are themes that come up with PTSD. So
Mhm.
each one of those integration sessions would be about something like that. And so the couple would be looking at that together. And it was remarkable. They did the worksheets, and then we would meet, and yeah, it
Wow.
worked really well.
Okay. Oh, that's interesting. So when we talk about integration, sometimes, I mean, one of the pitfalls of psychedelic work is getting mystical all the time.
Mhm.
And I think it was Jack Cornfield that said, "After the ecstasy, the
The laundry.
laundry,"
Yeah.
right? And so sometimes integration really means doing something pragmatic, like, okay, you got to go to the grocery store.
Mhm.
Like, you got to eat, you got to go to the grocery store. So, I mean, is
Yeah.
that fair to say that sometimes integration, while it may have this really big kind of life perspective, it may be as simple as like, I got to go to the store.
Right. Exactly.
Yeah.
And also, I've got to be with my emotions.
Mm,
For people with PTSD, you know, being with all of the emotions is a lot of work. Uh, Feeling their anger instead of numbing,
yeah.
and so that would be part of the work that the couples would be doing together. But I mean, not dissociating and learning when you dissociate, and how to become more present. Yeah. So integration is a huge part of it, and
Yeah.
not easy, not always easy. I mean, you might have had some blissful times, and you might be feeling the energy to heal, that you're in a healing process, but it can
Mhm.
also be a lot of hard work,
Yeah.
painful
Yeah.
work.
What would you say to people that were afraid to feel their emotions? Because that is so common in PTSD, and this feeling of, geez, if I feel my emotions, I'll never be able to control
Yeah.
them again.
Well, working with the anger in the sessions so that
Mhm.
some of it can come out, and they're not carrying that around. Feeling joy, feeling good is also hard work for people with PTSD. They've shut out all the emotions, and so helping people go back to things that they really love can be part of the work.
Mm,
If they were singing before they did PTSD, or if they liked music. So bringing music, maybe having music from the session that reminds them of some of the ways they felt during the session. If they felt good, can be something they could take home and start to do that. So whatever practice could be something that helps people feel good.
yeah.
Um, and all of the emotions, grief, lots of grief work,
Yeah.
and also suggesting ways that people can sit with that, when they're home, when they're not with you, and then also doing it with you with support.
Mm-hmm.
They see
Mm-hmm.
you the next time.
Yeah. 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 You mentioned the music, and I've seen that be really important with study subjects where, people that didn't meditate because they couldn't sit still.
Uh-huh.
It's like the old saying, don't just do something, sit there, right? This person I'm thinking of could not sit there, but with music, this person could sit there.
Oh, yeah.
And they actually found music that was similar to the playlist that we used in the study, and said, when I put that on and I sit in my, where I meditate, I can bring myself back into that space.
Right. Yeah.
And I feel that same, and I feel that same kind of peace that I've felt in the sessions.
Yeah. That's
Yeah,
so nice when that happens.
yeah. So I have a last question for you. So just a preliminary. Oh, there we've got one more question actually. Okay, this is my second to last question then. So other than PTSD,
Mhm.
Pike is asking this, other than PTSD, are there other psychiatric conditions for which you'd like to see MDMA assisted therapy research? You talked about depression, couples
Yeah.
work.
Couples work, hospice work.
Mhm.
Um, you know, just thinking about the people that healthcare workers that have been
Yeah.
part of COVID and what they're carrying.
Yeah.
Yeah. Conflict resolution. I mean, the autistic spectrum has already been looked at with the social anxiety, but maybe more of that.
Mhm.
Um,
Okay.
More people with life-threatening illnesses, that's already been looked at, but obviously more. Yeah.
So there's another question that just came in that ends with "Go Who's," which I think might be a regional reference that I'm not getting.
What,
Go.
what yeah.
It says, "What specific areas in the psychedelic arena may benefit from a nursing perspective? What would you improve about those systems, and how would you do things differently if you had the opportunity to change them?" And also, "Go Who's," which I think must be a sports reference.
Well, I mean, nurses are already used to giving medication,
Yeah.
and so they're used to looking for adverse reactions and talking to their patients about the medication and what's going to happen. So what specific areas? Yeah.
Yeah, I'm not totally sure what was meant by this. I'm wondering. I think a lot about how nurses co-create the space of healing with their patients. We don't just swoop in and do something. There's a line that you said in a MAPS bulletin years ago that I often quote about that. You can clean a wound, but you can't make a wound heal.
Mhm.
Only the body can do that. But it
Right.
does it better if you get the gunk out of the wound
Mhm.
first.
Yeah.
So I'm wondering, is there anything about how nurses hold that sort of space that could be informative to other professions, other disciplines in the team?
Well, yeah, I mean, nurses are inclined to do that and know how to have the environment like that. I mean, they're very observant about what the patient needs and patient care,
Hmm.
and specific patient care. So I think, yeah, I think they have that keen awareness already,
Yeah, we're attuned.
empathy, and
Hmm.
yeah, attunement to
Yeah,
what's needed.
yeah. Somebody else is asking what's your opinion about the use of MDMA in treating what's sometimes referred to as little t trauma? So
Yeah.
not necessarily criterion A,
Uh-huh.
PSM, but
Well, I mean, I think that always happens. You especially with our approach, which is the non-directive, trusting the inner healer to know what's needed to heal.
Mhm.
Very often, the big T trauma doesn't come up at first.
Mhm.
Little T's sometimes come up and need to be healed before someone is willing to go into the big T. Or, like one patient we had severe depersonalization and derealization, and couldn't feel the fact that she had a loving husband and this wonderful family.
Mm-hmm.
And so her trauma was actually rape from years ago, but before she could go into the trauma, she worked on feeling the fact that she was loved and she'd survived.
Mm.
So, you know, very often those things will come first, and lots of them, lots of
Yeah.
little T's,
Right.
things that you might not think were so traumatic, but participants sometimes get a different perspective on,
Mm.
oh, I thought that was really a lot worse than it was, after they're working with the MDMA, you know.
Uh-huh.
I've been carrying that as if it was, you know, really life or death, and it actually wasn't. My parents were trying their best at that point. So a lot of cognitive reframing around some of those little T's, and also some of them are bad.
Yeah. Yeah, for sure.
Uh-huh.
Yeah, and that some of it is sort of reinformed by compassion, that you can change your perspective, that, you know, like you're
Yes.
saying about parents, that, you know,
Yeah.
they may have screwed up, but they were doing the best they could at the time.
Right.
Yeah. Do you ever think this is going to be something that's done over telehealth? You know, I know some of the ketamine outfits are, you know, I wrote something in Chacruna a few months ago, you know, sort of a bad Huxleyan knockoff of, you know, what this could look like if it was done badly, and, you know, very little supervision, or, you know, you're just being watched over a webcam. You know, do you imagine that happening in the future?
No, I mean, but it probably is happening at some, I mean, it's happening with ketamine.
Yeah.
So yeah, no, I mean, I think, especially, you know, what we're talking about and what I am familiar with is PTSD.
Mm-hmm.
So I think about the people that I've worked with, and I would want them to have full support of two people there, so they could really feel like they could go into whatever's coming up. I mean, I don't know how somebody could really trust that they could go into what's happening at home,
Right.
unless they, I mean, especially with PTSD, you know.
Yeah.
And you want them to really be able to do that, because that's how the medicine seems to help, is, you know, help them go to those places that they couldn't go in regular therapy.
Right. Right. And that, you know, just because you can do something with fewer people or in a cheaper setting doesn't necessarily mean it's wise. You know, I mean, I'm thinking probably a lot of open heart surgeries could be done with one surgeon, but, you know, maybe having two there is a good idea, right? You know,
Yeah.
just because it's cheaper to do it with one doesn't mean you necessarily want to. I want the plane that's being flown to have two pilots in the cockpit. I don't want to.
Yeah, I don't. Yeah.
You know, I live in fear of getting that call on the overhead. Is there anybody who's medically trained on this plane? You know, I don't want to be asking if anybody knows how to fly a plane. That would be terrible.
Oh my God, geez.
Yeah. So last question for you. You know, you've been a nurse for a long time, and, you know, you've really enriched us with your experience here. And, you know, nurses are, you know, pretty hard on each other. Sometimes, you know, the old nurses eat their young thing, but they're also really hard on themselves.
Mm-hmm.
You know, they often really are almost hardest on themselves. You know, and I'm just wondering if, when you go back and you think of yourself as, you know, a young nurse just starting out in this, is there any advice that you would give yourself now, looking back?
Well, I think it would be along the lines of, well, trusting my intuition and trusting myself more, but also how long it was going to take to do this work. I might have told myself, you know, this is a path, a lifelong path. And it's been worth it for sure. You know, I wouldn't rather have done anything else, but I think I might have liked a little more awareness about how long it might take us to do this and get this drug approved for people. I mean, I feel really fortunate that I've been able to work with people and see how it has seemed to help them. But, you know, we still have a ways to go.
Yeah, and many, many miles before we sleep, right?
Yeah.
As the
Yeah.
saying goes. Yeah.
Yeah.
Well, I want to thank you so much for
Yes.
taking this time with us. I mean, you really, I think for every year you've spent in this doing this long road of bringing this work this far, you've inspired hundreds of people, and I know, from our page that you are definitely a hero of many people in
Mm.
our organization, myself included. So I really want to thank you for taking the time to share some of that wisdom with us tonight, and hope we get to do this again at some point in the future.
Pleasure, Andrew. It's been really fun, and
Uh,
yeah, I hope people have gotten something out of it.
yeah, I know they have. All
Yeah.
right, Annie,
Thank you
thank you
for
so
doing this.
much. Yeah, thank you. Till
All of
next
you
time.
that have done this organization, thank you.
Thank you. Till
Yeah.
next time.
Okay.
Okay, bye.
Bye.